Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Hello, everyone, and welcome to the Mad in America podcast. My name is Brooke Siem, and today I have Dr. Gretchen LeFever Watson. Dr. Gretchen LeFever Watson is a developmental and clinical psychologist with postdoctoral training in pediatric psychology. She has served as a professor of multiple disciplines at universities and medical schools in the United States and abroad, and as the patient safety director for a large healthcare system. She secured millions of federal dollars to study the epidemiology of psychiatric drug use and to develop community-based strategies to reduce over-reliance on psychiatric labels and medicines, strategies that also improved educational outcomes. In 2008, BMJ vetted her for a list of 100 international scientists who journalists can count on for unbiased reviews of health research. Dr. Watson is an academic affiliate at the University of South Carolina and the author of an Amazon bestseller, Your Patient Safety Survival Guide, How to Protect Yourself and Others from Medical Errors. She lives in Virginia Beach and loves to windsurf. Thank you so much for being on the Mad in America podcast today.
Well, thank you, Brooke. It's great to be here and great to see you.
You know, it's interesting, Gretchen. I did not know that you were one of the 100 international scientists who journalists can count on for unbiased reviews of health research. I want to initially take that and go a little bit into your background. I wasn't so sure we were going to go deep into this, but after seeing that, I think it's very apropos because you had to earn the right to say you were an unbiased reviewer after a very interesting series of events that occurred around your ADHD research. Can you give us a little background on the work you've done with ADHD and what happened in the late 90s and early 2000s?
Sure. There's a lot packed in there, but in the late 90s up through the mid 2000s, I was conducting studies to look at the prevalence or epidemiology of ADHD. And what I was finding kept differing from what the ADHD quote unquote experts were saying. You know, the Dr. Joseph Biederman of Harvard and Dr. Russell Barkley, they kept saying, we have so few children diagnosed with this condition and far too few of them who are diagnosed aren't medicated. We need to make sure more children are getting diagnosed and they're getting medicated because having unmedicated ADHD puts children at risk for all kinds of bad outcomes, particularly later substance abuse disorders. And I was seeing something very different. I took a job in a department of pediatrics out in San Diego, right out of graduate school. And I was part of a multidisciplinary team within a department of pediatrics that assessed children for all kinds of learning, behavioral, school problems, things like that. And while I was there for 3.5 years, we almost never diagnosed a child with ADHD. In fact, the few times we did, it was because people were insisting there was a problem and we had looked carefully and we could find no other explanation for the children's difficulties.
Roughly what year was this?
This was the early 90s up through 93. And then the pediatrician who was heading that team, a developmental pediatrician, retired from the military. It was a pediatric department in the Naval Hospital, San Diego, and got recruited to go to Virginia to open up a new neurodevelopmental center. So he moved from San Diego to Virginia Beach to do that. And a year later, the military also relocated my family from San Diego to Virginia Beach, and we ended up unknowingly being neighbors. And when he found out I was 2 streets over, he came over and said, Gretchen, you've got to come help me again. And we're going to build the exact same kind of multidisciplinary assessment clinic here in Virginia Beach that we built together in San Diego. So we started running multidisciplinary assessments.
What is a multidisciplinary assessment?
So we had children would come in with some sort of concern, and they would be seen by a developmental pediatrician, by me, a clinical psychologist, an educator, a speech pathologist, a language pathologist, an occupational therapist, physical therapist, social worker, the whole gamut. And we would all do our independent assessments of the child and then come together and pore over the data and try to figure out what was going on with the child and how we might help that child and family succeed. And it was a great success in San Diego. And we had lots of referrals and long waiting lists in Virginia Beach. But in Virginia Beach, all of a sudden, he and the other developmental pediatrician that was part of our division were diagnosing lots of kids with ADHD. And I kept saying, gee, what's going on? You guys, why are you calling this kid ADHD? I just don't see it. What are you talking about? Where is this coming from? And challenging them just clinically. And, got a lot of pushback. And I kept, advocating what I thought was right for the children. And I was being basically discounted. And so I took it upon myself to finally go through our clinical records. And I looked at the first 188 consecutive cases that came to our clinic. And over 75% of the children were diagnosed with ADHD. Some of the children were clearly having significant problems. Long story short, my pediatric colleagues were saying, you're just observing a referral bias. We're new in town and we're dealing with a backlog of people who need these evaluations. And we're just seeing all the kids that exist in this big metropolitan suburban region known as Hampton Roads, Virginia, or Southeastern Virginia. So I said, well, how do I take a look at this issue where I can get away from the referral bias, because I was seeing ADHD being discussed everywhere I went in town. My daughter was in kindergarten by that point. Her classmates were getting diagnosed. Adults were talking about it at cocktail parties. And I was like, this just doesn't make sense. So I approached a pediatrician who'd been brought to town to set up a research center and increase research among the pediatric faculty. And I said, I have this idea. I'd like to do something. He said, just write a proposal. I'm like, oh, what do I need to do to write a proposal? He said, just answer these 5 questions. And I came back and he looked at my proposal and said, this is one of the best proposals I've ever read. You have to do this study. So I did the study. And then I said, okay, now I've got data. You really must listen to me now. And we had an incredible opportunity where all of the school nurses in the 5 districts in Southeastern Virginia wanted to collaborate with me on that study, because they said, we see every day that we're giving, back then it was mostly Ritalin and some Adderall, to too many kids. It's getting ridiculous. We have these long waiting lines outside our nursing clinics, and we keep talking to the superintendents and special educators, and they don't listen to us. We're just school nurses. So if we can help you collect real data, that would be fantastic. So we were able to look at the school health records of every single student in 2 school districts in Virginia. And we looked to see if they had a diagnosis of ADHD and were taking a medication specifically for that diagnosis.
About how many students was that?
It was about 85,000 students in one district, and I think 15 or 30 in the other.
Okay, so this is not small.
Not small. This was a massive study using a very conservative method for deciding if somebody was an ADHD case. Count them as a case. There had to be a form in their school nurse record saying that they had this disorder. They had to be taking medication for that disorder in the middle of the day from a school nurse. And that form had to be signed by a physician stating this is medication for ADHD. So any child who was taking medication, for example, at home before coming to school and didn't need a midday dose would not have been counted in our sample. We also excluded all the students who were in full-time special education classes, because we knew many of them were diagnosed with ADHD, and we wanted to make sure we didn't in any way overestimate the prevalence. And so when I got that data, I had 8 to 10% of the children in grades 2 through 5 were diagnosed and medicated in school during regular school hours. And that might not sound like a lot now, but at the time, the ADHD experts were saying, only about 3% of the kids are diagnosed, and maybe only half of them get the medication. So that would be a very small percentage of kids. So I said, well, that might be what's happening in some places, and it might be a national average, but it's clearly not what's happening in Virginia. We proceeded to look at this issue repeatedly. We did serial epidemiologic studies using different methodology, and we kept getting the same results. And when we looked at children diagnosed but not captured by school health records, the numbers doubled. And of course, the rate was much higher among boys than girls and much higher among white students than Black students. So if we looked at the most affected group, the white boys, 33% of them were diagnosed with ADHD. And when I looked at the medication they were on, 28% of them were on 2 different types of psychotropics simultaneously, usually a stimulant and an antidepressant. 8% were on 3 different types of psychotropics, and 1% were on 4. We're talking about elementary school children before the ADHD craze really took off. So the more I kept producing data that challenged the narrative that too few children are diagnosed and medicated, the more I came under attack. You know, it's really funny, Brooke. When this all started, I was painfully shy. I never would have gone into any of this if I knew that it was going to attract media attention. I just back then wanted to be, flower on the wallpaper, and definitely was not looking to try to do anything controversial. I was just trying to get straight answers and make sense of what I was seeing. But it did work me out of my shyness. And I just didn't back down when, I'd be on a national stage and Barkley would go after me and try to really intimidate me. And I knew the data were solid. So I just stuck to the data. And when I didn't back down, the nastiness, if you will, intensified, and ultimately Barkley published a paper calling for basically an investigation of me, implying that I'd done something wrong. And within days or weeks of that, my medical school also received an anonymous complaint that I had fabricated my data to suit an anti-medication agenda. And then we were off to the races.
The races. And you when were all cleared?
2006. So it took two years. So for 2 years, my research was put on hold, which if you have active grants with federal funding and you do nothing on your grant for 2 years, you get in a lot of trouble and you lose your grant funding. So that's probably part of the reason that this investigation, which should have been pretty straightforward, took 2 years.
What I find out about the story is that you were the child psychologist in the room, correct? But it was the pediatricians who are starting to diagnose ADHD, not the child psychologist.
Right. So they were developmental pediatricians. So this is what they specialized in. And the lead developmental pediatrician said, basically, if we don't diagnose them, there will be no reason for the community pediatricians to refer patients to me. They'll just refer them straight to you. So he was worried, in part, that his contribution to the multidisciplinary evaluation might not be necessary. So the way another pediatrician explained it to me, and this is an exaggeration, of course, but your general pediatrician sees a lot of runny noses and earaches, and they don't get to see a lot of really interesting cases day in and day out, because pediatrics, like other parts of medicine, has become so specialized. So you have pediatric cardiologists, endocrinologists, and so on. And so he said the general pediatrician really wants to maintain control over ADHD because it's kind of new and it can be interesting. It's a pain to deal with, but it gives general pediatrics some level of importance. And so there was a little bit of turf battle going on between general pediatricians and developmental pediatricians. There was money at stake. At one point, I found out that what was going on. I would write my psych reports, the speech pathologist would write her report, and so on. And then the developmental pediatrician was picking parts out of our report to incorporate into his report. And that was, for a while, the only thing going out back to the community doctors or schools, unless somebody requested more. And sometimes our reports were even changed. So they were incentivized to give the diagnosis and then medicate and follow up.
What about this drew you in? What was it that made you say this is not just strange, but also that this might be a problem?
I had the luxury of seeing children for repeated evaluations sometimes and seeing very young children. So I saw things like a 2-year-old who came to me who was diagnosed with ADHD. Again, we're talking mid to late 90s, 2-year-old diagnosed with ADHD, put on medication for the condition. And the parent came back because she was very worried. Her child wasn't acting up anymore, but didn't seem himself. And I was just kind of mortified. And I did a careful evaluation and I said, I don't think he's hearing well. Have you had his hearing tested? Well, it turned out that he had chronic problem with fluid on his ears, and he had lost some hearing loss, had some temporary hearing loss. They addressed that. He didn't need the medication. They got him off the medication, and he did great. And I would see cases like this, and I would just be, banging my head thinking, how are people missing this? I had multiple times referred children back to the neurologist to say, I'm concerned this child looks like they might be having petit mal seizures, not ADHD. And every time I referred a child back for that, that came back as a positive result. So you have to wonder how many more kids was I missing that might have been suffering from petit mal seizures and having, blank stares that are being interpreted back then as ADHD. And the pediatricians were, the pediatric specialists were really eager to show that they had something really special going on. They knew how to diagnose these kids. And so, ego was involved too.
How did the pediatricians square the fact that there's no real legitimate test for this, that it's just a collection of symptoms? It seems to fly directly in the face of medicine.
Well, what they say is you have to do a very careful developmental history. I was watching a very prominent kind of Hollywood doctor just in the past month or so on a very prominent YouTube channel. And this psychiatrist was explaining how we have brain scans now that can help us diagnose this condition accurately. And that's very important because if we diagnose children accurately, then they won't be at risk for developing substance abuse from their stimulants. But, I'm not sure anybody participating in the show really picked up that when pressed, he said, well, of course, a critical part of the diagnosis is a careful developmental history. Brain scans really don't diagnose any ADHD. You and I know that, but the average person doesn't. And when you have this doctor who's got clinics all around the country, and he's literally made billions of dollars doing this, people want what he's got, and they definitely want to make sure they get these brain scan assessments so they don't end up giving their child a medication that they shouldn't have. And if he says they have ADHD based on the brain scan, then they don't have to worry about addiction to a highly addictive drug.
ADHD and Adderall is very alluring. And I don't think that there's any denying that almost anyone who spends some time on Adderall is going to feel different and probably going to like the way they feel. And maybe it's going to be easier for a short period of time. And, with the breakdown of community and with the breakdown of stability and the family unit and faith of any kind and financial worries, and also there's no community support, there's no outlets, kids can't go outside anymore. So it's just kind of like, I get in some ways why people are so drawn to this, because it seems like it solves their problem. And also we have become so horrible at critical and long-term thinking.
You've brought up so many great points, Brooke. The drug for most people, quote unquote, works initially, and it makes people feel good. Not always as much with young children as adults, but it will subdue their behavior. And what I saw clinically happen over and over was that a child would go on the medication, a stimulant, they would behave better for a while. So the parents would think, oh, the child really does have ADHD. And then they would adjust that level of medication, and they would up the dose, and they'd go through this. And eventually the child would start getting irritable, or they couldn't manage that kind of dose. And then the parents would think, well, maybe he doesn't need the medication anymore. And they tried stopping the medication. And of course, as you know, as well as anybody, you can't just stop these drugs and expect that there won't be some fallout from it. Sometimes there isn't, but often there is. And kids would often then act really irritable and cranky. And the parents would say, oh, he really does need his medication. And back they'd go. And then I'd watch them go from the stimulant to an antidepressant to a combination to mood stabilizers to, before you know it, they were on an antipsychotic. And that was happening by 2000 with disturbing level of frequency, let's put it that way, in southeastern Virginia. Now that's happening all over the country with lots of kids. But back then, we were a pocket within the US where that was happening. And I watched it unfold. And I know that if I had come out of graduate school and that was my first job placement, my first job was there in Virginia doing what I was doing, I might not have realized how wrong it was. Or it might have taken me longer, but I had such a contrast with working in a setting where money was not on the table because everything was covered as part of military benefit. There was no billing paperwork to submit. And my postdoctoral training was the same thing. It was at a government-funded program at Georgetown University. So we were just incentivized to do what was right for the children, not anything beyond what they needed. And so those contrasts really helped me understand how perverse the whole thing was.
So with ADHD, you had mentioned that there was something like a risk of substance abuse, or at least that was kind of the narrative. But where did that data even come from? Are you telling me that there's actually a long-term studies following people in the psychiatric world? Because that's not something I come across very often.
Oh, Brooke, this just shook my world at the time. So Joseph Biederman, who's now deceased, was a Harvard child psychiatrist who was called, I think, the father of psychopharmacology or pediatric psychopharmacology. And his colleagues, Baroni and Willens, published a paper in 1999 in Pediatrics, which is the journal of all journals that really most influences clinical practice as far as everyday treatment of children in this country goes. And this study got unbelievable media attention. And the abstract, I think, said that this was a large study. The title said that early treatment with, for ADHD prevents later substance abuse. And it was just news all over the place. So I wanted to get my hands on that study. And when I did, I was just dumbfounded. First of all, it was a very small study that was incredibly poorly designed. And to get the results they wanted, they had to torture the data using a particular statistic that I'd never heard of. I went to a PhD biostatistician and said, "Do you know what this is?" She said, "That's a statistic that's used for looking at how metal bends when we're building bridges. What does that have to do with this study?" I'm like, I have no idea. It's using this statistical procedure that they got this result. And there were, I think it was 19 kids in one of the critical cells. We're talking about a tiny study of 137 children. And every newspaper just about in the country blasted that study as saying early ADHD drug treatment prevents later substance abuse. And that study made the rounds in the media for years. If you or I or most anybody submitted that paper to any halfway reputable academic journal, it would have been thrown out. But this was the father of child psychopharmacology. He must know what he's talking about, I guess. And, and also my first study that came out in the American Journal of Public Health that really got a lot of national media attention, I first sent it to pediatrics, or one of the major pediatric journals, let's just say that. And it got favorably reviewed by all three reviewers, but two of them said to reject because the paper suggested that Ritalin was being overused. And so the editor rejected the paper. Again, we're talking about 30,000 subjects in this study versus 137, and various rigorously designed and conservative methodology, et cetera, et cetera. And it was rejected because they didn't like the message. They didn't like what the data were telling us. That was a rude awakening for me as a young academic to know that such a prestigious medical journal would do something like that.
It's why I get really frustrated when people, beat the drum of believe the science. I almost married a PhD, and I was shocked at the amount of corruption and academic incest, I'll call it, and collusion and pettiness and backstabbing that would go on in the world of environmental politics research. And now pulling back the curtain on what I know about medical research too, it's like, yeah, I love science as much as anybody else, but that does not mean that there are not a lot of bad actors and that things have not gone quite wrong, even if it ends up in a major journal.
Right. I like to think that the percent of bad actors is really small. And what happens is there are a lot of people who aren't as well educated in scientific methodology as we presume. So, you put a few bad actors with some people who might have some weaknesses in critical areas of research and analysis, and you get what we have now.
And then combine that with a world that's increasingly more difficult to exist easily in. Mm-hmm. And it all just feels like a solution somehow.
Right. Yeah. Yeah. You were asking me before about what really is the pressure for parents getting their children diagnosed for ADHD. And one of the things we didn't talk about is just this fear of success that really took off in the 80s. There's the woman who edits the Psychology Today blogs did a wonderful job really analyzing that in a book called Nation of Wimps. And she said after the economic downturn, there were parents who were really afraid of how were their children going to make it in the world that seemed so competitive. So that was one of the factors. But, like you mentioned earlier on, too, it's taking off in the adult population like wildfire. There was an article in the Wall Street Journal today or yesterday about how many investment bankers in New York City are abusing stimulants to manage their 90-hour work days. And there's a doctor in town that they know and was mentioned in the Wall Street Journal article by name. They go to him, he maxes them out on Adderall, and then he tops it off with, Vyvanse so that he's not technically exceeding the recommended dosage for one drug, but he's giving them multiple stimulants. And now he's also running an addiction clinic out of the same office because, of course, many of his patients are getting addicted to a stimulant because it's a highly addictive substance.
The switch to adult ADHD has been fascinating because what I hear a lot is people will reach out to me because they were diagnosed with depression, given an antidepressant. Maybe they got off of it. Maybe they've gone through withdrawal, but the end of the story so many times, and it's just been this has changed in the past 2 years. the end of the story is, but as it actually turns out, I have adult ADHD and didn't know, and now I'm medicated for that and everything's fine.
Yeah. Well, think about it. Brooke, you're going off an antidepressant. That doesn't necessarily feel good. So if you're one of the people who has struggled to get off an antidepressant, and really they have some stimulating properties to them, right? And so you're going through withdrawal, you're trying to readjust, your brain is trying to readjust, you're reorienting your life, and somebody gives you a stimulant, you're going to feel better. And people are still falling into, wow, if I'm having a reaction to a stimulant, then I have the disorder that stimulant corrects. Just like, oh, the aspirin helped with my headache, so I have aspirin deficiency disorder. It's like, how we get so sucked into believing because we put a name on something that it's a real disorder is astonishing. I mean, psychiatry really did a great job convincing the public that mental health disorders are real medical diseases.
That we can test for.
That we can test for, but we can't. And when I say that to people, they look at me like, maybe you haven't kept up with the field or something. No, I think I have. I think you're just buying what they're selling.
Because we want to. We want that easy flow.
Yeah. And last month, did you see the Department of Justice did come to a plea deal with Cerebral, the online company that hired Simone Biles, the gymnast, to advocate for ADHD. Yeah, so that company popped up around the pandemic and took off, and in 2 years was estimated to be worth $4 billion. And they got caught for pressuring their clinicians to diagnose ADHD and to make sure that 100% of their patients who had uncomplicated ADHD were on a stimulant.
Which basically makes them a pill mill.
A pill mill. I mean, this is legal drug dealing.
Yeah.
So they had to pay what seems like a relatively small fine and agree not to write prescriptions for Schedule II drugs in the future.
So if we've effectively established that there's no real research that indicates substance abuse will occur should ADHD go unmedicated, what do we know does tend to happen for kids who have been diagnosed with ADHD and medicated from a young age, long term?
Well, there are lots of different pathways. Some kids go on it for a while and then they reject it on their own and are able to stop and they do fine. Some more often stay on it for a long time, and then they usually have a cascade of prescriptions and diagnoses that follow. So if you stay on a stimulant for a long time, you're at risk for, ironically, becoming depressed. So where it gives you a lift for a long time, at some point there's a switch where you start experiencing more of the adverse effects of the drug and fewer of the benefits of the drug. It's a curve that's very predictable in that it almost always happens, but it's unpredictable in terms of when it will happen for any given individual. So it could happen for me quickly and for you slowly. So that's part of what this cascading, this prescription cascade and diagnostic cascade is all about. And when we look at children and middle school, high schoolers, college students who are given prescriptions, stimulant prescriptions for ADHD, they are at much higher risk of abusing the prescription. And we also now know that that problem has become worse every year for the past 20 years. The stimulant misuse, abuse, and addiction. But also, there's a really great study that came out that was able to show that the percent of children diagnosed and medicated in middle or high school with ADHD was predictive of prescription drug abuse among all the students in that school. Some people can use it and they don't experience adverse effects, but it's, the DEA has said since 1995 very clearly, this is a highly addictive class of medications. And the FDA just issued new box warning labels to go on all stimulant medications. And again, we know people don't really pay attention to those box warning labels, but at least they're there, and it makes it easier for us to educate the people who are interested in learning that these are indeed medications that have a high addictive potential. So, why would you put your kid on that if you didn't need to?
I'd love for us to end on a little bit more of a positive note, and let's talk about what you've learned about how this can be managed without medication.
We had a great opportunity with funding from the U.S. Department of Education to go into a school and train teachers in positive ways to manage behavior in the classroom. And it was a, tough sell because I'm not a school teacher. So teachers were kind of grumbly, like, who are these psychologists coming into our classroom, making us sit in teacher training, and they're going to tell us how to run our classroom, which I totally understood and was very sympathetic to. And we were teaching them, we did pre and post assessment of what they understood and did all kinds of things. And we were trying to teach them to use positive techniques frequently, reinforce what you want, catch the kids being good, use punitive interventions very sparingly. And one of the interventions that you can use effectively in a classroom is timeout. And the teachers, 96% of them used it. They all said, oh, I've used timeout. It doesn't work. So my colleagues and I realized, well, timeout is one of those things that sounds so simple, like a lot of good behavioral interventions, but it's actually easy to screw up. So we went around to every teacher's classroom and we had them show us where their timeout spot was and how they used it. And 95% of them used it inappropriately. And we said, here's what you need to do. You have to have a timeout spot where you can keep an eye on the student you put in timeout, but the student loses all social connection with his peers while he's in timeout. They really don't like that. So we literally walked around the classrooms and we moved file cabinets and did whatever we needed to do to make a timeout spot work for them. Well, that gave us a lot of traction with the teachers. And then the real breakthrough in getting the program running was I said, we're telling the teachers that they should give their students positive feedback. Maybe we should give the teachers positive feedback. So I had the research assistants who were going in and making observations in the classroom stay there until they found something very specific and genuine that they could give the teacher positive feedback on. And they had to write a positive note and put it in the teacher's mailbox. And it had this little bit of magical effect where teachers started saying, okay, we'll do what you're asking us now. And they started putting the interventions in place. And what happened was from the beginning to the end of the year, we saw a 70% reduction in discipline referrals compared to the previous year. We saw ADHD symptoms in the classrooms that took on the positive behavior management decrease as a whole classroom from the beginning to the end of the year, whereas in the other classrooms, these symptoms increased. And we got students' academic scores. And if a teacher was in a classroom that took on these positive behavior management techniques, they had students who scored significantly higher on every subject area of the standardized test. So we knew this wasn't just teachers giving good grades. They were all taking the same test. And these results were highly significant across all subject areas. So that really helped teachers to understand these things make a difference.
I was reading up on this, and you identified 4 gaps that you noticed and around ADHD. And those 4 gaps are behavior management, school provider communication, teacher training and education, and parent training.
Mm-hmm.
Children aren't mentioned once on that list. What does that say?
Oh, I love that. I hadn't even noticed that, Brooke. Thank you. Yeah, the problem is not the kids. See, ADHD puts the problem in the kids. The kids are not the problem. The kids are trying to adapt to their environment with whatever they bring to the table. And when as a child psychologist, I avoided working with children as much as possible directly, because if I do therapy with kid, that child has to go back to the same parents and the same teachers. How much better to get the teachers and the parents to change their understanding of who the child is and what the child needs than to tell the child there's something wrong with them. So, that was our general strategy. But, the parenting program really scripted off that too, where I said, look, parents need these basic skills, but nobody wants to go to a parenting class. Who goes to parenting class? The perfect mom who's going to show up and show everybody that she's already doing everything right. Or it's the child protective services parent who's forced to go if they want to get their kids back. So it's just a bad setup altogether. We said, we are not going to call this a parenting program. We worked on the name a lot and came up with A+ behavior, helping your student, not even your child, your student excel in school and at home. And I trained the people who delivered the program. You may not mention the word parenting. So we delivered basic parent training without ever mentioning parenting or making the parents feel like it was about them fixing something wrong in them, just giving them basic skills. And we had parents loving it. 100% of them who signed up for what we thought was going to be our 3-class series wanted more. So we developed an advanced set of classes. 100% wanted to sign up. And teachers said, can you run one of those classes for us? Can you run it at my child's school so I can participate as a parent, not a teacher? People just ate it up. It's just basic information that's really helpful. And no child needs to be pathologized to learn how to make their lives better.
Is that information available anywhere anymore?
This was probably one of the most disheartening things about having my research shut down. That program was so well received by teachers that we were able to get the school superintendents from 5 different school districts to agree to allow their school psychologists and school counselors get trained in it so that we could create a train the trainer model so that every elementary school across this huge area of southeastern Virginia would offer this basic training. And we were at our ready to run our last train the trainer session when I got a phone call saying, you will be fired if you finish that training. So it all stopped.
Maybe there'll be an opportunity to bring that back. Seems like deeply needed.
Yeah, basic education help people. I mean, one of the things that's so basic too that we didn't talk about is just the whole concept of, is ADHD even real?
I wanted to ask you that question, and then honestly, I got a little scared. But you brought it up. Is it real?
I know. I'm, for a long time, I didn't want to address that head on because I'm afraid parents and others just tune you out. But I think we really have to find a way to explain to people that just because we put a name on a set of behaviors and claim that it's linked to a brain disorder doesn't mean that it is. And to this day, after 5 decades of this work, we have no evidence that it's a brain disorder per se. And we have one of the fathers of ADHD, Keith Connors, saying before he died that it's a fabricated disorder. And he's the person who put it on the map. It's a most interesting story. Have I never told you about this?
No.
Well, Keith Connors was working with another prominent psychiatrist at Harvard, and they were doing studies to look at the effect of methylphenidate on children who had an early version of what we now call ADHD, who probably really did have some brain pathology, neurologically related brain pathology. And they were approached by one of the drug companies that made stimulants and said, hey, how about if we turn your research instrument into a behavioral rating scale that can be used to diagnose kids? And the rest is kind of history. Of course, he made a name and millions of dollars by continually updating the Connors Behavior Rating Scale, which became the most widely used rating scale for diagnosing ADHD. And at the end of their days, both Keith Connors and the psychiatrist who he was working with publicly confessed that it was a fabricated diagnosis. And Connors said it's a concoction used to justify giving out medication, period. I mean, his exact quote is just chilling. So, that's where we are.
How in the world was that not the headline of every major newspaper? I mean, I know the answer, but
I know.
My goodness. Well, Gretchen, why you pay attention to history class and try not to believe anything blindly, because there's always more to the story. Thank you so much for being here with us today. Where can the world find you?
Well, people can always email me. My email is out there. They can find me by going to drgretchenwatson.com. Happy to keep helping people make sense of how we've been fooled about these diagnoses and how medications will fix them.
Thank you so much for all your work. Keep going.
Thank you, Brooke. Bye.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.